weekly PMHNP coaching call that we're doing. So I'm doing this coaching call with the students in my program, and so yeah, it's time to get live, and let's do it. Okay, what up, what up? So basically, can y'all hear me? All right, checking. Perfect. Let me pause that. Hey, how's everyone doing? All right, give me a 1 if you can hear me or not. Wait, are you wait, are you guys able to hear me?
I can hear you.
Oh, okay, perfect. Okay, I thought I was yapping to myself for for a little bit there. Okay, awesome. Good to see y'all. Good to see y'all. All right, looks like we're starting strong. So I am going to share my screen. Perfect. Y'all can see my screen. Okay, let us resume recording. Perfect. So now we're recording. And excellent. So yeah, why don't we start going through everything? So Richard, I saw that you had joined the call, so maybe we could start with your case first. You're here with us, right?
Yeah.
Okay. Awesome. Good evening. Yes. So you have succeeded. We have switched over to Monday nights due to your your convincing arguments.
And I thought that we were gonna have a paradoxical effect from that joke. I left. I had 0 likes. So I was hoping that maybe I had a comment by the end of the week, but I don't think anybody found it to be funny.
It doesn't matter. The result is what's important.
Wonderful.
Yeah. So anyway, okay. So you mentioned, so you have this case. So a 21-year-old female. The patient has OCD, MDD, alcohol, a lot
Use
of
disorder.
PTSD, right? So there's definitely a lot that's going on here. It looks like there's some OCD as well. So referral from PCP, right? OCD 2. So history of pandas here, panic disorder, GAD, ADHD, and then this is her medication regimen. So the clomipramine, the Abilify, the Effexor. So yeah. So my question. So tell me about your case. What are your thoughts? What was your reasonings?
So I went diagnosis by diagnosis. The one that I could not dive too deep into was probably the PTSD. I ran a PCL5, which is scored about a 50 something. It's evident that there is PTSD symptomatology relevant to her day to day life. This is the one diagnosis that I regret not going into deeper, but given the fact that there was so much to go over, I was short on time. Her main concerns are that of OCD. Fortunately, she suffered an SA about 3 years ago, which relapsed her OCD to drastic parameters. She explained to me not being comfortable over the intrusive thoughts. Unfortunately, she said that she's too embarrassed to speak about them. They're so severe. They are also awful. And she used a few other words to describe their intensity. Therefore, I cannot provide specific details. But what we do know is that at this present time, with this current regimen, she has about 4 instances of intrusive thoughts that she's able to cope through, though she experiences great challenges. And overall, she wishes to one, mitigate this, and number two, find some kind of treatment for her ADHD, which after going over the specific details of it, I do think that she has it from a category of maybe mild to moderate. And it definitely falls into the attentive side. This one was prevalent since I think she said high school early on when she started taking more robust classes like AP and honors, and has been a problem since then. Though she has somehow managed to cope through all the way until now that she's starting her bachelor's. My idea is to maybe capitalize a little bit more on the Anafranil because it has that TCA effect, which also is covered by, we can find that same effect on Effexor. She complained from insomnia that interrupted by diaphoresis. She's sweating at night. She did agree and correlated the sweating with the titration of Effexor. She started having like maybe a 150. So I was like, okay, well, maybe FX is not doing us too well, and we can get that maybe the same coverage from a TCA anyway. So might as well increase that Nafranil so that we can target that low serotonin that we theorize is occurring in her brain and causing OCD. Reduce the effects of where we added, and my concern in addition to it is that stimulants may exacerbate OCD, though I have not seen in clinical practice. I would love to hear your experience on the matter, in addition to discussing anything else about her case.
Yeah, gotcha. So thanks for breaking that down. So let me share a couple thoughts with you. So right now with the Effexor, how effective does she perceive it to be?
She finds it to be effective to manage the anxiety, even to the point that she has not experienced any panic attacks. And I think I verbalized that somewhere like in a month or two.
Yeah, so last episode was approximately 4 weeks ago. Okay, so that's worth noting then. Uh, so basically, when I'm trying to think of clomipramine, there's two approaches to this. There's one that's augmentation, and there's the other which is using as a replacement. So let's say the primary agent gave minimal benefit, then it's an easy choice, right? Then you can just say, okay, we'll use clomipramine as the primary agent. But this is harder because she's actually had good benefit, it looks like, from the Effexor. So then by decreasing that, we risk destabilizing her in that regard and hoping the clomipramine may or may not help. So let me ask, the clomipramine's benefit is primarily for OCD.
Correct, yes.
And this is something that you had started, or this is something that the PCP started?
PCP.
PCP, okay. So clomipramine can be used as augmentation for on SSRIs as an SNRIs. Of course, you just need to be careful with it due to cardiac risks. Here, Effexor can increase blood pressure. Clomipramine can sometimes decrease blood pressure because of orthostatic hypotension. So that can actually be a benefit to you here. Like you can almost counteract the blood pressure increase from venlafaxine. So my thought process would be that if you want to use clomipramine, you just titrate it up slowly, but you use it as an augmentation, and then you track her OCD benefit that she gets. A further benefit you might receive is from ADHD as well, due to the changes with the norepinephrine. It's not as strong as it is for venlafaxine, and certainly not as strong as a stimulant, but you might get some benefits there too. So that's my one thought regarding that. The second thought with ADHD and OCD is that sometimes treating the ADHD can make the OCD better. And the reason I say that is because imagine if in OCD you have these thoughts that are happening, and with ADHD there's decreased control of the frontal lobe, so the OCD thoughts kind of go haywire. Whereas if she's able to have better control of her frontal lobe, then that could make OCD better because she's able to rein in the thoughts. They're not as intrusive. She's able to catch them, let's say the first or second time, rather than the fourth or fifth time. But it could also happen the other way around, in that the OCD tends to be a higher activity in the frontal lobe, which is why she has too many thoughts. Like, it's almost like an overactivity, and that's why calming interventions help with that. It's almost like things are too focused. Like the frontal lobe, the cortical striatal circuit is too active, and that's why the thoughts keep hitting over and over. So that's how stimulants could make it worse, is because they will overstimulate the frontal lobe. So my thought process would be that if you suspect it's truly OCD and not just ADHD thoughts that are going unchecked, then definitely prioritize addressing the AD or the OCDs first, and that may also improve ADHD symptoms and allowing her to focus better.
Okay. So what you're telling me is that the regimen could be directed to either or options. I'm not truly sure what will happen, and meaning me, have to do a really good job in assessing the source of the OCD before prescribing an stimulant.
Exactly, yes. Assess what the source of the OCD or the ADHD is exactly. Is it a primary ADHD that's stemming from childhood, or is it more of a secondary one that's related to her dysfunctional thoughts with the OCD?
Okay, I see. I was thinking that maybe the ADHD did come prior to, since it was first noted in high school. And specifically, was able to correlate it to taking more robust classes. I was asking, what were you doing that it was maybe now a challenge to focus on school? So, I was getting more serious about school, and the year prior, I asked my counselor to give me some honor classes. So that's when I found a gap in my ability to do well in school.
I see. Okay. You think, was there any comorbid anxiety around that time?
So there was a lot of pressure from mom to do well
Yeah.
in school. She verbalized that all throughout the interview.
Yeah. Got you. Okay. So there could be some of that struggle as well too. Like, it may not just stem from a primary frontal lobe deficit for the ADHD.
Okay.
Yeah.
How do you think I should direct that assessment to dive deeper into the differential?
Yeah, you're saying how should you assess for ADHD versus OCD? Is that what you're saying?
Right. How can we look a little deeper to see which is the underlying mechanism?
Yeah. So one, I would ask what she believes it is, because oftentimes the patients have a gut thing. The second would be to walk through a detailed timeline. So walk through, okay, in college or in elementary school, what were you experiencing? Okay, in middle school, what were you experiencing? In high school, what were you experiencing? How did performance evolve? When did you start noticing intrusive thoughts? When did you start noticing anxiety? When you go through a detailed timeline by timeline, like, you could even break it down. I've broken it down, for example, like grade by grade, when I've needed to. Like grade 9, what happened? Grade 10, what happened? And then you can really start to get an assessment of how the timeline evolved.
The pandas came around age 9, I believe. So, which is earlier than the ADHD.
Right. Has that been addressed?
What do you mean by address?
Like, has she had any kind of functional medicine workup? Has there been a strep workup? Has she had antibiotic treatment? Is there current strep antibodies or strep activity still?
I did ask about the treatment she provided. She unfortunately does not remember all the details. I think asking mom may be beneficial. She said she thinks she was prescribed antibiotics.
Okay, but she's not 100% sure.
Correct.
Yeah, you could actually check for the antibodies right now too, for the strep antibodies. But
strep?
but you don't really, like, that's not really in your purview. Like, you could if you wanted to, or you could refer her to functional medicine, make sure it's still been addressed.
Functional medicine. Alrighty. So if I understand you correctly, we're thinking that the ADHD, from the information I'm presenting, is more of an anxiety mechanism rather than a true ADHD that is an ability to concentrate.
Yeah,
Okay.
I suspect it's secondary. And then another thing that could be helpful is clonidine and guanfacine. Because now, if you're suspecting there's PTSD stuff from the SA that she had, she could just be hyper aroused a lot from this. And so, clonidine and guanfacine could be calming a lot of that hyper arousal that's going on.
Understood. We now worry about the anafranil making it giving her any form of dizziness or hypotension in combination of clonidine or guanfacine.
No, we would be worried about it for sure. So I would say
Okay.
prioritize this first and then see where this gets you. And in the future, you could consider that as well.
Okay, wonderful. So the decision I made last time I saw her, mind you, it was the first visit, was to increase the clomipramine just a little bit to see what results we get, and possibly the intention of dropping down the effects are just a little bit. I want to make very small baby steps. Do you think that is a wise decision?
Yeah, I think it's reasonable. Are you trying to discontinue her off effexor, or are you trying to just lower it enough?
I would like to lower enough so that we can mitigate that nighttime sweating, which is one of the reasons why she's waking up.
Yeah. So did you lower it to 187?
No, I have not lowered. I simply increased the clomipramine.
Click clomipramine. Okay. Yeah. Yeah. Because you don't want to if you do the two things at once, and let's say she has a worsening in anxiety, we don't know if it's the effexor decrease. We don't know if it's the clomipramine increase.
Correct. Yeah, I think that's a good thinking. I increased it to 50 milligrams, and I asked her to follow up as recent as a week. So I should be able to catch her pretty soon.
Okay, nice. Yeah, I'm curious to hear how she responds. Yeah. Anything else on this case?
Well, I think that the only question left remain is if she doesn't improve the inattention matter after we manage the OCD and anxiety better. Do you think that at that point we can tolerate a stimulant trial?
Yeah, I mean, low dose stimulants are certainly used in these cases, so you could certainly use it. Yeah.
What I worry about is the expectation that coming to me for the management of ADHD. It seemed like she was really focused on is very in line of her values to do better at school right now. So it's an expectation she has at the forefront of the treatment.
Yeah. Okay. So that can be helpful because then you can guide her to getting towards that. For example, you say increasing the clomipramine will help you with performing better in school because it's going to reduce some of the OCD symptoms you're having.
Okay.
Yeah.
Sounds like a good approach.
Yeah. Use her motivation to help you, not to harm you.
Got it.
Yeah.
Wonderful. And in the meantime, the only detail I haven't added is I asked her for all the progress notes from the PCP. Just maybe I can find something interesting, and asking for an EKG because usually whenever I see a TCA, I like to have one if possible, and more so with a stimulant on board.
Got you. Yeah, I think that's reasonable.
All right, appreciate it.
Awesome. Okay. Then you could also add supplements too. For example, N-acetylcysteine could be added. Yeah, omega-3s. Like those won't harm her at all.
Got it. Thank you.
Yeah. So, okay. Now, okay, Janet, are you here with us, Janet? Okay, let's see. What about Natalia? Or Sarah? Actually, I think we do see Sarah here. So let's go through Sarah's question then. So
yeah, I'm here.
Okay, awesome. Yeah. So you mentioned the oxcarbazepine taper. So you got a 21-year-old. She's taking oxcarbazepine 600 XR, wanting to switch to Lamotrigine. Um, she's done well, but she's had hyponatremia, doesn't like them, bladder spasms. Okay, wants to go to Lamotrigine. So yeah, what are your thoughts on this patient? What are you thinking?
Yeah, so she came to me residential after more of an acute stabilization post pretty significant substance use history and unmanaged bipolar, has a history of really not consistently taking meds. This is the first time she's stayed sober and taken meds consistently, probably since she's been 13, 14 years old.
Yeah.
She has been on Lamotrigine in the past and did okay on it when she took it, but because she's been on and off of it so much, the previous provider said it really wasn't safe, so wanted to switch her to the Triliptal, which she's done well on. Mood has been stable, no hypomania, no real depressive episodes. She's had this weird bladder spasm issue that I don't know that it's really related to this medication, but it's been getting worse. She really doesn't like the large pills. So today she kind of hits me with the, I want to switch. I think she's done well, but also it's her choice ultimately. So I want to honor that. And also it's the first time she's really invested in her care and her treatment. So I think it's a big shift for her. So I want to keep her involved and motivated in it, because I think that's a big part of keeping her invested long term.
Mm-hmm.
And these are big changes that we've seen. Like she's chosen to stay residential for longer than expected. So all of these things are big changes for her. So I want to kind of keep drawing her into that. So I think it's okay as long as we do it the right way. But my concern is the switch over, because I've not had patients on the Triliptal before, and then the switch to Lamotrigine. I don't want to do anything to kind of rock the boat and risk a manic episode or a depressive episode, especially since she's also on the fluoxetine.
Mm-hmm.
So I'm kind of neutral, but I'm a little nervous.
Yeah. So let's walk through all of those things. So the first thing that you said was you want to really work with the patient and like use her motivation, which I think is really good because now you're thinking deeper. You're thinking like you're using the psychological aspects of our relationship with the patient deeper, and it's not just like you're just going by the book, what the book says, because this is what separates us and what separates good providers from not, is that we can think through the nuance like that. So if that's what she wants to do, she's bought in. Her main reason is the pills, the bladder spasms, right? Like how strongly motivated is she towards this change?
I think she's pretty motivated. And knowing her, once she gets something in her mind, it's there.
Got it. So in her case, then, that's what we're going to be going with, right? So if that's the case, right now, what is your thought process on how you want to cross taper?
I think she doesn't have, so she's not on it for any seizure-like activities. So I'm not necessarily worried about seizure activity. I don't think that there's any major interactions between the two. So I'm thinking to cut in half originally, and give that a couple of weeks, maybe 2 weeks.
Mm-hmm.
And then gradually increase the Lamotrigine. And then I'm wondering, she's been on in the past, would I just start again at 25?
Yeah. So I think that works perfectly. Lamotrigine and oxcarbazepine, they have similar mechanisms because they both do the sodium gated voltage channels. Obviously, they touch different channels and it's more complex than that. But the lamotrigine starting can help coming off of trileptal. And you're also correct that the trileptal, she's not having any seizures, so you're not going to risk putting her into any kind of seizure state with that. So I also agree with you there. And thirdly, and the 600 can be a starting dose for many people. So I don't anticipate her having a problem coming off. And she's only been on it for 6 months. It doesn't look like she's been on it for like 6 years. So that means she's much easier for her to come off it too. And then fourthly, she's residential. So you can easily watch her and you're not concerned about non-adherence or anything.
Correct.
Yeah, I think that's a great plan.
Okay, cool.
Yeah. Yeah, because if that's what she wants to do, she wants to go on the lamotrigine, she's more bought in, it's probably going to help her more too.
Okay. And then, so the taper, so the first half, a couple weeks, and then a couple weeks for that last 300, and then just completely discontinue and then keep rising with the lamotrigine.
I mean, you could even do it like she's on 600 right now, so you could just put her on 300 for 2 weeks and then keep her on the 25 of lamotrigine for 2 weeks. And then once she gets on 50 of Lamictal, then DC the trileptal.
Okay. Cool.
Yeah,
thank you.
I don't anticipate her having very many problems coming off of it. She's also young too.
Yeah.
Yeah.
Yeah. And she's in a good place right now, so I think it's a good time. She's a good therapist and a good support system right now. So if there was a time to try it, this would be it.
This would be it. Perfect. Yeah. Anything else on this patient?
No, I don't think so.
Okay, I'm going to turn on my lights because it's getting dark. Be right back. Okay, so that's that. And then our second patient is, so you said there's a 30-year-old ECT. Basically, they're having cognitive impairments, severe memory loss, struggling to function. Yeah, so tell me more about this patient then.
Yeah, so she has been through, this is her second round of ECT. The first one was about 1.5 years ago. This most recent one, the acute phase, finished up in about, I would say, January, and then kind of tapered down. Her last session was a few weeks ago. She's kind of toyed back and forth with doing maintenance. So the one shock every couple of months, weeks, whatever would work for her. Mm-hmm. Very, very significant treatment-resistant depression, but it seems to be improving a bit now that lithium levels are up. Nortriptyline is up to 150, and we added on Lamictal. Yeah. With further investigation this past week, we had kind of an emergency team meeting with her therapist because she was going to do another maintenance ECT session. It seems actually that ECT hasn't even really been super helpful in improving her mood. Mm-hmm. She had maybe 1 or 2 sessions that actually felt kind of what she described as joy and has been kind of chasing that since then, but hasn't really been having this mood improvement that she was hoping for since then. So she instead has continued the ECT, but is struggling to remember details about her job. Being able to remember daily tasks that she does, even with lists, being able to wake up and self-motivate to get this done, remember details of her life, memories back to childhood. She is starting to have some memories come back, but is describing them only as the horrible memories of her life.
Yeah.
So I think that there's also some fear now about the memories coming back because they only seem to be the negative ones. So she's really struggling, and there's this layer of she's wondering, should she do more? Should she not? And I'm kind of thinking she's now admitted that it hasn't been helpful and it's only really been impairing her memory more. And is there anything we can do to kind of boost what she has left?
Yeah, exactly. Because now when I hear this case, that was my thought, is that is she really getting much benefit from ECT if now she's not functioning well? She's having this cognitive impairment. She can't barely work, losing memory all the time. Do we know either if the ECT is bilateral or unilateral?
So it was bilateral, and then because she was also forgetting to tell them how severe the memory impairment was, and I kept telling them, and then they moved to just unilateral. But that was like only the last 2 step down sessions.
I see. Okay, so it's just been a recent change. Yeah, because in that case make it unilateral, and then they'll also decrease the dose of it too, or the voltage. Because it sounds like it's definitely impairing her. Other thoughts I have are the lithium levels. Do we know that they're not too high?
Yep, they're just at 0.8.
Okay, so it's maintained well there. And was there any correlation with these worsening symptoms and increase of nortriptyline?
No. If anything, they improved.
Okay, because the only worry I'd have would be the anticholinergic stuff. I mean, she's young, but just with all the stacking of it. So if that's the case, then does she want to quit ECT or stop doing it?
I think after this meeting that we had, she does, because it was kind of a come to Jesus moment of like, we're just kind of, it almost was like a chasing the high moment of we're looking for that feeling she had maybe once or twice and it isn't there.
Right.
So I think she's ready to not do that anymore. And now she's at that desperation piece of kind of what have I done and how do I get back what I've lost, other than trying to wait it out and hope it comes back.
Yeah, it's unfortunate for this patient because ECT is usually one of those last resort type of things, and you think it'd be helpful. Yeah, so my thought would be that, okay, if it's not working for her, let's just get her off of it, stop the ECT, let her memory slowly try to recover from there. Is she taking any supplements?
At this point, she doesn't, and that's kind of where I was hoping you could guide, because some supplements I think might be helpful in this.
Yeah, the ones that I think of would be, for example, omega-3s would be really good. Checking, make sure there's no nutritional deficiencies, the foundational stuff. So zinc, magnesium, iron, thyroid, B vitamins, homocysteine, methylmalonic acid, making sure that there's no, for example, the B vitamin deficiency or any of the others, because those are what I would just consider the foundational things. Any of those corrections could help her as well. Let's make sure that I don't know when her last labs were done, but she's on lithium. So I just want to make sure that her thyroid is still functioning well too.
So her thyroid is actually, she has a very minor hyperthyroid. And that was before the lithium. So we do need to retest her thyroid. So I'm in Vermont, which is basically like the slum of where any kind of medical specialty goes to die. So getting patients into specialties is hard. So I did put in a referral to endocrine, and I got a call from endocrine saying that they couldn't see her because they only had an NP that does diabetes management. So now I'm doing a new referral over to Dartmouth for endocrine for thyroid, because to see if there's some correlation. But this has also been a very long-term.
Sorry, I think you cut out for a moment. Is it me or is it?
No, I couldn't hear her either.
Okay, yeah. Yeah. Sarah, are you with us? We can see you. Can you see us, hear us? Okay, yeah, I think she got muted. She'll be back.
Can you hear me now?
Yes.
I don't know what happened. That's another lovely part of living in the middle of nowhere, Vermont, where
Yeah.
technology goes. So basically, her hyperthyroid level, it's been kind of consistent for a while now. Referrals out, wait times are long, but that's definitely on my radar. But that was going on long before even the first round of ECT.
Got it. Okay. Yeah. So the sounds like the thyroid's already been going on. Omega-3s would recommend. B vitamins can also help her too. Also, phosphatidylserine. That's one that's used in a lot of cognitive impairments. So you can definitely look at that one as well too. I wouldn't want to start her on like 50 or something, but yeah, phosphatidylserine is definitely another quality one too for cognitive impairment. But then I would also make sure to check the nutritional deficiencies too. Because lithium could have messed with her kidneys as well too, which could have messed with other levels.
Okay, great.
And then in terms of any other type of medication, if she's having cognitive impairment, Wellbutrin, modafinil, even like a low dose stimulant, those could be helpful too, especially if cognitive is a big concern for her.
So she is on 70 milligrams of Vyvanse.
Oh, okay.
Yeah, and she does have a history of misusing immediate release stimulants, which is why we went with Vyvanse. And that's one thing we have to be careful with her, and she self-tattles basically and supports well to help manage her stimulants. So she definitely is that, and she was on Auvelity before and did okay on it, which is like the Wellbutrin cough
dextromethorphan,
dextromethorphan combo, but Wellbutrin, we could add Wellbutrin, just give her a little bump.
Yeah, just be careful, because that could help her with the depression as well. Obviously, check out her EKG, of course, just make sure she doesn't have too much stimulation going on. But Auvelity could be a nice combo too to really get her cognition increased, because that will also help with NMDA and glutamate signaling, and that's really helpful for cognitive benefit as well. So that's not a bad idea either.
Awesome. Great, thank you.
Yeah, of course. Anything else on this?
No, I think that's great. Thanks.
Yep. Okay, so now we have Janet here. So she mentions that there was a 78-year-old female on Ativan, 3 milligrams, sertraline, and Geodon. She fell, oh poor thing, and then Ativan was lowered. So then Richard had mentioned, replacing the sleep aids with less impairing agents. Yeah, basically the 78, Ativan, 3 milligrams is a pretty significant dose for her age. So I'm glad that it was lowered. The environmental changes, occupational therapist was mentioned. She doesn't use the walker. Maybe she could get a smaller walker, use a cane. But yeah, occupational therapist would be most helpful as well too. So sounds like that was pretty much taken care of. Adding in mirtazapine, low-dose mirtazapine. Low-dose trazodone can be used. Doxepin as well too, 3 to 6 milligrams. Yeah, anything else on this situation? No, okay. So Natalia says, talk about diagnosing adult ADHD when there's not a lot of clear childhood history, distinguishing what's MDD primarily, or if the MDD is a result of untreated ADHD, right? So using standardized testing. Seems a lot of patients with other diagnoses meet criteria for ADHD. And then people are also self-medicating, which can affect the cognitive executive functioning. Yeah. So the way that I think about adult ADHD is, one, I want to assess the childhood stuff, if there's anything that's going on, walk them through it. But if there isn't, I still am more liberal with diagnosing adult ADHD for me, because I want to make sure that we can get the patient the best improvement. And if it takes a diagnosis to get them improvement, whether it's from insurance coverage, whether it's from stimulant usage, then I tend to go with that. Also, you want to assess if there's anything else that's going on. So that's where the timeline really is helpful. So, for example, distinguishing what is MDD or GAD primarily, or if it's the result of untreated ADHD. You want to assess if the mood, anxiety symptoms are causing the focus problems, or the focus problems are causing the mood and anxiety symptoms. For example, I had this 18-year-old patient, and she works in her dad's company. And I think I've shared this anecdote before. She was working in her dad's company, but was struggling a lot, having a lot of anxiety, felt like she couldn't keep up with the demand. So she came to see me for focus, anxiety, feeling frazzled, low mood as a result of that, not feeling capable, that type of thing. And so I did a deep dive and assessed basically the timeline, and it seems like for her, she was having focus problems earlier in school, but she was smart, so she was able to overcome a lot of it. And then when she joins the dad's company, that's when a lot of the mood stuff started. And I just asked her, what does she think came first? And so she said she believes the focus issues came first before the mood and anxiety stuff. So then we started to treat her for that. So I went with Strattera for her, because I knew that that could be also helpful for any anxiety or depression things as well. And that made a huge difference for her. So that could be one thing to do, is use something that can help comorbid. I've had other cases where I remember I had an ER nurse, and so she was having and treated ADHD as well as the MDD and GAD as well, so kind of combination. So with her, I went with Effexor to address the focus issues as well as the anxiety issues with that. And then for her, around 75, 112 milligrams, she did really well. So that's a case where you could use comorbid, or you could use a treatment that's comorbid, that can treat multiple things to really help in this situation. But then I've also had other cases where, for example, I had a kid come in who claimed he had ADHD, and he came in like that was the reason. And then started doing a deep dive, and I realized that there's a lot of mood issues and a lot of other like stressors, adjusting to college and things. And so I realized that, okay, I think this is more of a depression issue rather than an ADHD issues. So for him, I suggested, okay, why don't we go with Wellbutrin, so that way we can address both. And so that's what we did, and he did well. So that can be a consideration too. One, try to figure out which came first, ask the patient, or do a timeline analysis of which came first. Even if you ask the patient, you'll probably get a good idea of what the patient feels. And then second, finding out anything which is that you could comorbidly, that you could treat together, so that way you can address multiple birds with one stone. And then the third thing would be, if there's a substance, then you can find out what that substance does for them, because that will often cue you in for things. For example, if they take one of these and they say that it helps calm me down, my mind is just racing, it's just going, then you might think about, okay, then maybe this is an anxiety thing. But if it's like, for example, they take something like a stimulating substance, then you might consider that they have ADHD, that they're trying to self-medicate with that stimulating substance, like crystal, for example. Yeah. Any thoughts, questions on that? Is this a common problem that you run into?
I have seen a lot of overlapping. symptoms, and seems like kind of a 50-50. If we, a lot of time, I'll ask them, and especially if they're more medication naive, what are the symptoms that got you guys in? What's bothering you the most? And try to pull back a little bit more of the history layers. And it's about a 50-50 split. Some folks want me to focus on the anxiety part first, and then others want me to focus on the ADHD part. It seems like the ADHD folks that we target that first, the mood does lift and the anxiety seems to go down a little bit. I think when we target the anxiety first, it's kind of just kind of individualize the results. But yeah, I have seen a pattern of just kind of all this overlapping with GAD and MGD and then ADHD stuff.
Yeah, I agree with you. Actually, I've had cases where I target the ADHD first and things get better. And this is a shift from how a lot of people are traditionally taught. They're taught that, you treat the anxiety and depression first. For example, I remember in my residency, a lot of other providers, like my co-residents, were very adamant that you want to treat anxiety and mood issues first. And that's because we had a more population who tended to really seek out stimulants. So I think a lot of them just became jaded. But that doesn't mean that the patient won't benefit if we treat the ADHD first.
Okay.
Yeah, anything else on that? Yeah, go ahead.
Yeah, I just wanted to add, if I may interject, this is something I see very commonly because I currently work for the VA. TBIs may also be another common reason for developing ADHD as an adult, especially if it hits certain regions of the brain that work with executive functioning.
True.
I think that we already spoke about quite a few of my VA patients and how they often manifest ADHD-like symptomatology.
Yes, that's another really good point too. TBI, it will pretty much cause all the different symptoms. Because the way I conceptualize it is all of these are different issues of the brain. So if the brain is messed up, like in a TBI, then you're going to have sequelae of all these different types of symptoms. So really treating underlying TBI, with hyperbaric oxygen, whether it's with omega-3s, clean diets, seeing neurology, all of that can really make a difference too. Yeah, anything else on that? Okay. So it looks like that was everything out of here. And then I went through some of the other questions that were here too. So for this one, the augmentation strategies. So Levita, yep, I got your handout. So thank you for that. I'll get the updated one that you sent and upload it to the classroom. And then Diana, so you mentioned about the Geodon to Abilify taper switch. So this is, I never even knew about this website right here, SwitchRx. So thank you, Richard, for sharing that. This is great. Like I went through a couple test scenarios and yeah, I think it's great. Was this something that you use commonly?
Yes, especially for the days that I'm bogged down making a lot of decisions, I think that it helps to have that additional help. Most of the times, it always comes down to decreasing or increasing the medication by about 25% for the majority of them. Some other times, I have more nuanced, specific suggestions as per the medications are being switched. So, all in all, I think it's great. This is quite the guide.
Yes. I think the important thing to remember is that just like it says suggested tapering and titration schedule. So just suggested. Ultimately, the decision is up to you as the clinician to what you want to do. Because something I was looking at, for example, so let's say we want to switch from, I don't know, olanzapine, you're on it for 3 to 6 months. Let's say they're on it for 20 milligrams to Abilify, let's say, due to partial response. So when I see that, right, what I've noticed that this does is it wants us to titrate the olanzapine first, or the Abilify first, and then once it reaches therapeutic level, it wants us to decrease down the olanzapine. So that is one approach. But another approach is to, as you're increasing the Abilify, to also be going down on the olanzapine first. So I've noticed that this does it like this, like that way. It wants us to increase one before bringing down the other. But then at this peak junction here, this could be too much for the patient if they're already on Abilify and they're on olanzapine too. So I like to bring it down. I like to start bringing it down sooner as I'm doing the titration. But that's just that's why there's multiple approaches, and it really depends on the patient. Have you noticed this, that they go with this approach with different medications too?
Yes. It's pretty comprehensive, I'd say. Since there's so many different variations, it does give sort of like a general guideline, but this is a specific example I haven't come across. This is certainly out of the norm.
Yeah. Actually, I'm just
Did it provide some references at the bottom?
Let's see, clinical tips. Yeah, so I mean, it definitely provides a good amount of stuff here. But I see clinical tips. I don't really see references. So, for example, see for here, for quetiapine, it says to basically bring up the quetiapine over, let's say, 2 weeks, and then to suddenly drop the lorazepam when you get to the top here too. So I think it just gives us one approach, whereas another person might start to taper down the lorazepam slowly. So overall, I'd say take this as a guideline, but then ultimately you make the decision based on what you want to do. Some patients definitely they want to taper. Like they might feel uncomfortable if you tell them, "Hey, I'm going to just drop the Latuda suddenly," even if pharmacologically it might make sense what you're doing. Does that make sense?
Yes.
Yeah. Anything else on that, on switching? Yeah, then I went through some of these. So yeah, I think they were pretty answered there. Any other questions that we didn't talk about?
I do have a patient that I was debating whether or not I wanted to bring up if we happen to have the additional time.
Yeah.
This is somebody who struggles with the idea of being on a medication period. Unfortunately, she has OCD, more actions than opposite thoughts. I'm having a hard time remembering the specific details right now because I saw this patient not a while ago. But essentially, she will do very well if she were to even attempt to be on a medication. And I tried a lot of motivational interviewing. All the providers have also tried to be involved to get her on it. And I was just wondering, maybe you can lead me in a different direction, or at least help the patient reframe the idea on being on a psychotropic in order to start feeling better. I'll give you an example. She looks at the worst case scenario for any particular medication, looks it up immediately in just about any website, and finds the worst possible symptom, which we know that all medications have adverse effects. So she fixates on those symptoms and does not want to give it a try whatsoever. I just don't want to keep this patient in limbo forever while her family is suffering as a result of the OCD.
Yeah, got you. So I have a couple questions here. So one, what does the patient want?
She wants to be anxiety free, OCD free.
Okay, anxiety free, OCD free. Is this what she actually wants, or is this what the family is pressuring?
That's what the patient wants. She's a mom of 3 kids.
And so my second question is, what does she want to do about this?
I think that she wants to improve all those symptoms, but without the adverse risk of any medication whatsoever. And she's also not open to therapy.
So she wants to improve symptom without side effects. So is she open to other modalities? Like you mentioned therapy.
No therapy.
What about supplements?
Supplements, I did recommend us Alexa, which is the over lavender essential oil capsules,
Mm-hmm.
and she agreed.
Oh.
But in reality, is I'm not expecting her symptoms to get a whole lot better. Studies have shown that Alexa is effective in managing GAD, but it comes short when it comes to OCD. It simply, to put it in simple terms, it takes the edge off.
Right.
And it doesn't treat it in the way that we would like it in a clinical trial, for example.
Right. Gotcha. But it sounds like she's open to it. Has she been compliant?
She's going to start it, and I'll follow up in about 2 weeks.
Okay. So in that case, I would consider saffron and NAC. Also magnesium. Because saffron I think of it like a natural SSRI. It's helpful for mild to moderate anxiety, depression, so that could be helpful for her. NAC, I pretty much give to all my OCD cases, especially when I'm starting out. It doesn't kick in immediately. It takes some time to kick in, but it's got some of the best evidence behind it. And magnesium can be given as needed or as a regular PRN or scheduled. Ashwagandha is also helpful for anxiety and stress. It's what we call an adaptogen, lowering cortisol response, release. So I think you could really just max her out on the supplement area too, if the patient doesn't want any meds due to side effects.
I think that's great options. I'm just worried that may not be enough, and that maybe walk me through this thought. Maybe if these supplements help to reduce the severity of her tendency of catastrophizing every medication before she even tries it, do you think that after being on the influence of the substances, whether OTC supplements or whatnot, she may be more open?
Mm-hmm.
What is your experience?
Yes. So I used to see a lot of this type at my last job. So because I was working at the Amen clinic before, and so at the last job, a lot of the patients come in, they wanted holistic things. They would get maybe, let's say, 25% better, 33% better from that, and then then they would be more open to medication, because one is that it could reduce the edge off, but then two, now she trusts you more, and so because now you've shown her her a small win. So now that you've given her a small win, then she's more willing to work with you further and further, rather than just the meds right off the bat. So it's almost like you're taking through a step-by-step approach rather than just taking her to the top of the line approach. And it may take longer for her to get better, but she's controlling the journey, and you're more like the guide for her. And so it's okay if it takes her longer. It's okay if she experiences more pain, because she is the one in control. It's like you tell a kid that they shouldn't touch the oven, but sometimes they have to touch the oven to know not to touch it. So it's better to think about this case more long term rather than the immediate, which you're like, okay, I want to get you as quick as better as possible. But if she's not willing to do that right now, we have to slowly let her buy into it, even if she suffers a little bit more on the short end, because that's what she wants to do.
So yeah, it sounds very reasonable now that you mention like this. I think that what I was also looking for is more options other than Sanlexan. I think that the NAC, for example, is a good idea. I didn't think of that. I do appreciate the suggestions.
Yeah, absolutely. And then what about blood work as well, too? Is there any kind of nutritional deficiency, zinc, magnesium, vitamin D, thyroid, anything like that?
Um,
Check her
I have.
cortisol. Yeah.
She actually came from the same PCP as the previous patient that we presented, and I can have access to those labs. Yes.
Okay. Yeah, so maybe you can see what she's had done so far and then add on anything that hasn't been done. Because the PCP labs will be very general.
Mhm.
They'll be what we call level 1 labs where they tend to just look at the basic yearly stuff, but then they might not look at vitamin D or hormones or cortisol or uh, zinc, for example, or magnesium. They might not look at some of the deeper stuff.
Okay. Sounds great. Unfortunately, she's not even willing to do any other labs. We went over that idea. Um, she was struck with a dirty used needle, honestly, within the last year, and now
Oh,
that is part of her phobias. She has breached her therapeutic alliance with many of her providers.
I see. I see. Well, then you have to work with her, right? Right. It's the saying goes is that, right? You can lead the horse to you can lead the horse to water, but you can't make him drink, which is true. But you can increase the chances the horse will drink if the horse stays in the desert for longer, if they get thirsty longer, if they start experiencing more discomfort, if their throat starts itching. Essentially, the more pain that the horse experiences, the more motivated they will be to take future action. So she might be in a case where the anxiety and OCD are not detrimental enough for her to get the higher medication option. So sometimes, part of her long-term journey is letting her reach that point.
Got it. All right. I want to say that her symptoms are severe enough that they're distressing, but to her, the idea of getting more ill from the potential effects of the medication do not outweigh the benefits of any prescription meds.
Yeah, of course, and that is her choice to make.
Right.
Maybe
Okay.
something like TMS could be a consideration too.
PMS? Oh, um, that will be an interesting choice to bring up to her.
Yeah,
Um,
I doubt she might not go for it immediately, but just something to keep in the back of your head. It sounds like for her, the supplement, natural, holistic approach might be the go-to right now, and then
mhm.
you work with her over time.
Okay. I hope that we have a fruitful relationship. She's been through a lot, and she's a mom. She used language such as, "I know my family is really getting over me. Like I fear that my kids are not going to love me because every time they look at me, I'm in the middle of another crisis." So it's really hitting home in areas are very painful.
Yeah.
Um,
What?
Hopefully this route can be beneficial.
Yeah. What about this therapy? What's her opposition to that?
Well, that's a good question. I want to say that she brought up something regarding her now wishing to open up, but either I did or we spoke about it, I don't remember, or we may have spoken so briefly that I do not recollect the details. It's been a little bit.
Okay. Yeah. No worries. Then. Yeah. Maybe next time, just explore it.
Um,
Yeah. And anything else? Any other questions anyone had?
I have a quick question.
Yeah.
I have a 45-year-old male that I've been seeing for a couple months in the group home setting. Originally, he told me that he had bipolar 2 disorder, depression, ADHD as a child, generalized anxiety. I had started his care. He was on olanzapine. he did want me to restart his ADHD meds. So going back in his history a little bit, he started to use substances at age 9. I asked him about any like delusional disorders, any history of psychosis. He told me that he had a depersonalization episode at age 20, but it was around very heavy like cocaine use. He denied any family history of schizophrenia, but his grandmother was a practicing witch. So he didn't really want to go into like further detail about that. And the more times that we've met, he started to share with me the delusions that he has about this meta universe and artificial intelligence. He wouldn't give me eye contact at first when I first met him. And he told me, he was like, it's because, you're a female and I get nervous around females. So I thought it was more of an anxiety thing, but now I'm starting to think it's more delusional. So anyway, fast track a couple months now, he self-discontinued